I've been doing the anteroblique approach for probably about 8 years. My oldest patient, I think, is almost 8.5 years out. Before that, I did direct laterals for about 3 years. Before that, I did the first cadaver truck that Reggie Knight taught, and I'm a chicken. And so I did the cadaver truck twice. I did 2 other vendors courses before I did my first direct lateral, and I initially used them as salvage procedures, and we'll talk about that. And then eventually they were doing so well, the direct lateral became my primary procedure. And then I had one femoral neuropraxia and started to dance around with, the shallow docking, the pre-Psoas, all those things. And eventually, now I'm fully anterior to the psoas, and I haven't neuromonitored in about 1.5 years. And so for me, that's about 200 levels. I think of neuromonitoring as another set of eyes now. I only use it if it's going to be hard to see, as in a deep patient where I need another set of eyes. But other than that, I don't use neuromonitoring at all because I'm always pre-Psoas. So let's figure out how to advance the screen. So why do we do these? You guys have already talked about all this. We do this because it's fun. I hate to sound too simplistic, but I do these because they're fun. I'm 53. I've been in practice 21 years. And I find that the anterior approach with less invasive posterior operations has allowed me to extend my career, save my neck, use less x-ray. And for me, it's been very predictable, tolerable, durable, and enjoyable. And for me, it's also been just a superb operation to prevent the flat back that we all get. But I have quite a few Cliff flat backs out there. And I'm sure some of them ended up in Rod's lap. And he's very kind to not call me and yell at me about it. So as you guys have talked about, patient selection, that's the most important thing. If you look at this was one of my first patients. This was a patient who'd had 5 prior laminectomies, unilateral, bilateral, whatever. This was one of my first 3 or 4 DLIFs. And this showed me the power of this operation. And we'll get into the indirect decompression idea. But for me, it was, he already had a laminectomy. Why go back? What he needed, as Rod said, is he needed foraminal height. And so an anterior operation can give them foraminal height better than anything. This patient, we all see these if you do pain diagrams, this patient won't do well no matter what we try. So my opinion of my first case has changed and is completely the opposite, unfortunately, of what you guys have been discussing. I used to think that L3-4 was the easiest case. Because the psoas was a little smaller, maybe the iliolumbar vein was nowhere to be found. But I noticed through the years, and I'll show you pictures of these, that L3-4 had a few anatomical variants to the unfamiliar anterior surgeon. I think the L4-5 level is more predictable. So for me, this was the perfect first case. This is a patient, obviously, with a grade 1 L4-5 degenerative spondylolisthesis, a predictable looking MRI. The iliolumbar vein will be crossing below it, and a nice reduction with an anterior cage. This is a Medtronic cage, rotated pretty well. Some of mine are not rotated perfectly. And then this was done a few years ago where I actually did open medial cortical screws. Now, if I got good reduction on the table, I would probably just do percutaneous fixation. And during one of the questions, it was asked, how do you decide indirect versus direct decompression? I now ask the patient that if when they're sitting down, they have no leg pain or buttock pain, and that occurs when they stand up, that tells me that if I get a good radiographic reduction on the table, then I'm basically simulating their sitting maneuver. And if you sort of educate your patients that, well, a fusion is just portable traction, hold you in the same position whether you're up or down. If you're happy in your sitting position and we get reduction like this from the anterior operation, percutaneous fixation, even with facet, cyst, and central stenosis, has been very reliable for me. So, ideal first case. So, we already looked at the key films, the lateral x-ray, the sagittal MRI, and now here's the axial MRI. So we've got a beautiful OLIF window, loop of bowel sitting in front of it. That may or may not be the ureter. We don't care. And then we've got our lumbar plexus very far posterior. Pay attention to things you'll see here. And notice the asymmetry in the psoas muscle. Notice that there's something here with fat around it. You need to do sequential MRI slices every 2 or 3 millimeters. Your radiologist will try and cheap out. Don't let them. You've got to do sequential MRI slices to be able to follow that item and make sure that it's a fascicle of muscle and not a femoral nerve. A little bit of abdominal fat is helpful. No prior surgery on the left. The only thing you might accept is a hernia because it'll be far away from you. So I always have the patients, they always ask, why are we going through the side to get to the front when the operation's on my back? And I show them a cross-sectional view of how the weight-bearing axis of their spine is actually in the geometric center of their back. I show them a slice of T-bone steak, and I say, would you rather plow through all this or go in front of it through an OLIF window and just push things out of the way? And I'll tell them, and they ask, where are you going to cut me? How much are you going to cut? And I always tell them, well, we're going to make an incision in your side about 1.5 inches long, and then I'm going to throw the knife in the trash. And if you tell the patient that, then they immediately, their fears get calmed. You're doing everything bluntly. You're doing very little cutting. Yeah, I might tell them that I pull out the long knife to cut the annulus. Sometimes you don't even have to. But if you tell them we're going through the side to get to the front to work on your back, and you show them this picture on your screen in your exam room, instantly they'll get it. And they'll look at you and they'll say, I want that operation, because their previous 2 opinions before they saw you talked about a PLIF. And if you say, I'm not going to tear all this up much or at all, they'll say, let's do something anterior, either trans-psoas or pre-psoas. So pre-op planning. So here's a nice lateral view. Here's L4-5. If you can see, I don't know how what's projecting, you can see the iliac crest there. To me, early on, trans-psoas would have been hard to do. Right now, pre-psoas, or codename OLIF, or whatever brand you use, that's an easy shot. You can bend that pelvis, and you can get that upside pelvis down out of the way on the lateral, in the lateral position on the table. Now, I didn't show it here, but it's very important to have your ASIS. So you tell your radiology technicians to open the films up anteriorly, posteriorly to show your ASIS. And now I have my radiology techs open up the films on the AP view to get a sneak peek at the hips. Because as we all know, you've seen patients that have buttock pain and you focus on their back, but then when you look, they've got hip arthritis. And you ask them the questions that the orthopedic surgeons ask about climbing stairs, putting on their shoes. If those things are trouble, start thinking about hip problems, either intra or extra articular. So this is an easy shot for an anterior oblique operation. And I'll show you a few tricks that directly are a result of the fact that I'm lazy and cheap. So have that pre-op discussion, though. We've all had neuropraxias of one kind or another. No matter what we do, trans or pre-psoas, the genitofemoral nerve is at risk. So I tell people, and in my practice, it's about 5%. 5% of people in 1 year in my practice will tell me they still have about a lemon-sized area of some numbness on the front of their thigh. Why, when we make an incision up here, do we get numbness there? Well, just show them on the T-bone steak idea where the genitofemoral nerve is. Briefly mention to them ilioinguinal, iliohypogastric nerve. The region's a little different, but those might get a little stretched because they're retroperitoneal. Tell them that they're going to look like their neighbor who had a direct anterior total hip. Their sort of hip flexor lag is going to be very real no matter what you do for about a week or 2, sometimes 3 if it's multiple levels, and they'll look like their neighbor that had a direct anterior hip. Briefly mention to them that their sympathetic chain dysfunction is very real but very brief. I've seen it in several patients, including, for some reason, 2 dentists and my own mother-in-law. Right? It lasts about 3 to 4 months. Though my own mother-in-law was told she, about 3 months after her 2-level anterior surgery by my partner, she was told she had cellulitis in her leg. But what she really had for the slightly warm and redder leg was sympathetic chain dysfunction, which then resolved. So, post-laminectomy salvage, if we're going to talk about that as the first case, get your lateral bending film opened up to show you. I can't see it because I've got the GoToMeeting screen over it, but look at your ASIS. And then notice here, I've got one iliac crest above and one iliac crest below that disc. That means on the table, we can get into that disc with ease. But be mindful that when you're landing on the disc, you don't have as much common real estate under L4 and above L5 in this example. You've got a narrower landing zone. So pay much more attention on your lateral fluorofilm in the OR to make sure you land in the right place. So standing film, okay, opened up to see the ASIS. Here's the high-low crest idea. Again, sort of less common real estate, as we'll say. Now, you'll become an iliac crest connoisseur. I make fun of my friend Leonard Kabuli down in Dallas, and I call this a Kabuli type 1, where the pelvis is very flat. You'll see a Kabuli type 2 where the pelvis will drop off rapidly. So even if it's higher, a lot higher, maybe even up here, almost at the top of L4, a Kabuli type 2 that drops off, you can get in from the front, from the interlateral position with very little effort. High-low crest again, a Kabuli type 1. So, sagittal MRI, very slight hint of an L3-4 degenerative spondy. When you see this, make sure you get flexion extension films. If it doesn't line up a little on the MRI, it's probably not going to line up a lot on the plain films. Here's an axial MRI. Now, we'll have to run through this a few times. We've seen this twice. Pay careful attention, okay? So this is standard setup, anterior, posterior, left and right. And watch the vessels that coalesce here and coalesce here. And you're going to think this is the aorta, but watch what happens to this blood vessel. Here comes what you think is the aorta, but it flips. And the aorta is on the left, was on the right and flipped to the left. Let's run that again. This is why you can't cheap out. You've got to get sequential cuts, and you got to play the movie. You got to watch things drop all the way down. Don't skip. Don't skip the pedicles. Watch the movie. So, predictable anatomy. This is what we want to go for. Here's a nice OLIF window. This is probably maybe a loop of bowel or even duodenum. Who cares? The duodenum is retroperitoneal. We'll talk about that. If you can see a little bit of fat around a vessel in front of the psoas, you're going to be able to develop that interval. Now, as Rod said, right side, sure, you could go right side here. If this were degenerative scoli, you could go right side, and it wouldn't be a big deal. But like Rod says, if you're going to beat on something, you're better to beat on an artery than a vein. Here's the plexus back here, nice and predictable. Unpredictable anatomy, or predictably bad, right? So here's a big AAA, but this guy was a perfect candidate for an OLIF. He had a degenerative spondy, so we did an OLIF through here. I did this a couple years ago, and I've done 2 or 3 since. I'd not felt a AAA since internship 27 years ago, and it was kind of interesting. But you could develop the OLIF window, and what this showed me was how little vascular retraction you do. You basically tuck it under here and lift up the psoas. My analogy is we're lifting up the psoas like you're putting a 2x4 under a bag of dirt to see the grass under it. You're not really pushing the dirt back. You're just lifting it up to look. But you can see how that the psoas is a little more adherent here on the left than it is on the right. This may be what's called a Psoas Minor. Okay, we'll talk about that in a minute. But this is not a bad case. You don't have to retract the AAA. Unpredictable anatomy again. This is one of my own PLIF non-unions, like Rod. We appreciate the hooks and grabbers and shavers that we can get our own or other people's ununited L4-5 cages out. So this was I thought about this for an OLIF, but this was the left common iliac vein. So we decided not to mess with it, and we did a standard anterior right-sided retroperitoneal ALIF to get this cage out. So make sure you follow the movie, and if you see any object in this space, you got to know what it is. Avoid flat vessels. Flat vessels are hard to retract. Tubular ones are better. So let's go to the operating room. Let's go to the theater. Let's not have any drama. Let's preoperatively plan. And here's where my technique differs a little bit. So this is how I set up my room. So when I walk in the door, if you're thinking about your first case, your rep can help a lot, or your rep will get help from an experienced rep. When you walk in the room, you want anesthesia on the right. At least that's the way I like it, because you're going to stand on the belly most of the time. So you're going to set up the room as window side, clean side, dirty side. So the clean side is the patient's belly, your back table, your scrub tech. The dirty side is the door, the C-arm, your PA, and the patient's butt. So dirty side, clean side, anesthesia on the right, and you can put monitoring wherever you want. I don't use them anymore. But notice what I've done, put this red stripe here. I am right-handed, my PA is right-handed. You can put the C-arm in straight if you want, but I developed a strange idea where I push the base cranial and I push the C-arm from posterior cranial to anterior caudal. And what that lets us do is that lets my PA stand more cranial, I stand more caudal, and we're looking at each other square across the wound. We're not leaning over the C-arm. This also gives you a better view of L4-5, or if you're doing L5-S1 in the lateral position, this is the perfect angle for that disc as well. It doesn't give you a great view for L2-3, but you're looking at L2-3, so I don't really care if I have a planar view of the disc space most of the time. But just play with this if you're right-handed and move the whole C-arm. You won't have to lean over it as much. It's just a goofy trick that you're going to love, you're going to hate. Like I said, I'm lazy and cheap. I actually do mine on a bendy table. Why? Because we only had one Jackson table so long ago. And so I put them on the lateral position on this table and then flop them on the Jackson for the posterior operation. If you're going to use this table, you get to bend it a little bit and open up the ribs and the pelvis. That makes your first cases and later cases easier when you bend at this joint, if you put the pelvis caudal to it. But fill in this little gap because their pelvis will fall into it and the ribs and the pelvis will get closer together. As I tell my staff, we do it the same way every time unless it's different. But it really is the same way every time. Whether it's fat, thin, single or multi-level, virgin or redo, we do every case the same. Fill in that hole and it'll help. So, positioning and taping. I use 10 meters of tape. I've measured it. I'll position them. There's the door with the C-arm, the patient's butt's on that side. And I bend them just a little bit. A little bend never hurt anybody. A lot of bend, big problem. A little bend never hurt anybody. But what that does is that opens up the ribs and the pelvis a little bit, bending through that joint. In tougher cases, but I tape them all the same anyway, I run a piece of tape up their back, over their iliac crest, and down to the foot of the table. And if I've got a misbehaving upside iliac crest, then I can bend the table at this joint, put a little tension on that tape, and pull the upside crest a little bit caudal. I find this is very helpful. It also stabilizes the patient. Once we like our x-rays with a perfect AP and lateral of all the levels we're going to do, you may have to move the table a little bit to get a perfect view of every level, 2 more pieces of tape, and off we go. But remember to put the tape, if you're taping the patient, it's so basic as to be embarrassing. Put the tape on the notches on the rail. Don't put the tape on the good rail, because the retractor holder can't go on the notches. Put the tape on the notches where the retractor holder can't go. So, bending the table never hurt a little anybody. If you haven't seen the Tim Davis articles, this is a screenshot from one of his dissections. I happened to be there at this day, Tim does a beautiful job with these dissections, and it's worth looking at the Tim Davis articles or maybe even seeing a course where he does the dissections. He knows the retroperitoneal anatomy better than anybody. He's a physiatrist down in Santa Monica. Don't forget to pad the downside greater trochanter. The patients will sometimes talk about greater trochanteric bursitis on the right side from laying there for an hour. Here's the oblique C-arm idea. This is my PA. So here's posterior cranial to anterior caudal wig-wag. It'll give you the best view of L4 and 5. You're either going to love it or you're going to hate it. I set up 2 Mayos. I've got sort of an exposure and retractor placement Mayo, and then we pick them up and flip them, and I've got a discectomy and dilation Mayo. So the Mayos are pretty sparse. This is really all the tools you need for the whole case. I've traded out this Deaver for a lighted custom retractor, and then I've got a $6 off eBay medium ribbon retractor. The lap Kidner is very helpful as well. So when you make your skin incision, be aware of the cutaneous nerves. Be aware of the ilioinguinal and iliohypogastric nerve, which might pierce the abdominal wall right there. So after you make your incision in the skin, it's mostly blunt until you get down to your 2 layers, external, internal oblique, and sometimes transversalis. So make an incision in the skin, throw the knife in the trash, and then I use a long, like Metzenbaum scissors and a cob with a self-retainer to get down to those layers. Tease open the external oblique fascia, split it with your finger, tease it open, internal oblique fascia, and show this picture to your patient. Now you're inside the belly, going through the belly to get to the back. Now, since I'm a chicken, as I outlined, I use a medium ribbon retractor anteriorly because I find that it just protects everything anteriorly. So anteriorly, you're going to have the peritoneum, you're going to have the ureter, you may have the sympathetic chain, you may have an ascending lumbar vein, and it's just going to sit there, and if you bend it just right, it'll hook over the anterior abdominal wall like a clothespin, and then we put another retractor posteriorly, and you go to work with your long lap Kidner. As you put your finger in the first time, palm up, make sure you feel for the bare area. Rod will show you that in the lab. Feel for the bare area of the iliac crest. So if you can feel bare bone, you're a retroperitoneal. And as you flip your hand over to bring everything anteriorly, if you feel things that feel like guitar strings, leave them behind. That could be ilioinguinal nerve, iliohypogastric. Sometimes lateral femorocutaneous nerve is floating free in the retroperitoneum. Here's my setup. Here's our lighted posterior custom retractor. Comes with one of the sets. And then here's my armor-plated anterior medium ribbon. And you can bend this like a clothespin, and it'll stay there by itself. You can just work with your lap Kidner and get down to the anterior edge of the psoas and prove to yourself that you're anterior to the psoas. As my old chairman, Terry Light, says, named structures won't tear. So as you are pulling things anteriorly, if you find something floating, leave it behind so you don't tear it. Feel for home plate, the bare area of the iliac crest, where the iliac muscle comes up and stops. The transversalis and the internal oblique come down and stop, and there'll be a bare area of the iliac crest right there. That's home plate. If you feel that, you're a retroperitoneal. You cannot go wrong. You can feel that from L3-4, L4-5, L5-S1, if you're doing those. But the first rule is fly the airplane. Don't stare down the wound too much. If we go back to this, you have an incision on the skin marked with like a marker, like a skin marker. Look outside the wound every once in a while and make sure that you land underneath your mark on the skin. You can easily end up one level north or south. Just look at the skin and make sure you land underneath it. 95% of the time, if you make the skin mark properly and incise right there, 95% of the time, you're going to be able to land on the correct disc without ever shooting an x-ray. Spondies are easy to feel. This is why I like anterior psoas more than trans psoas. With a spondee, you can feel the overhang of 4-on-5 or 3-on-4 or 5-on-1. You can feel it anterior to the psoas, but you can't feel it if you're going trans psoas. So let's review anatomy real quick. This is from medical school. SAD pucker. SAD, suprarenal adrenal gland, aorta, duodenum, ureter, that's the U, but I call it SAD punker. We never learned in medical school that they're retroperitoneal nerves. So just remember the big three, ilioinguinal, iliohypogastric, and genitofemoral, and Rod and Yen can show you the femoral nerve, just the anterior to the transverse process. But don't forget the nerves in the retroperitoneal space. The colon is retroperitoneal, the kidney, the esophagus, and the rectum. What do you mean the duodenum is retroperitoneal? The duodenum, if we remember from the Developing Human book, the duodenum starts intraperitoneal, then rotates, the foregut rotates, and fuses to the posterior peritoneal wall, and then blends into the retroperitoneal. So occasionally you'll see the duodenum while you're doing this. Don't freak out. You'll know you're not intraperitoneal. If you can feel home plate, you don't have a big torn peritoneum, you're just seeing the duodenum in the retroperitoneal space. But the good news is you can see it. If you can see it, you won't hurt it. The genitofemoral nerve. This is why I switched from telling people L3-4 is a good starter level. They usually starts at about L2-3 and it pierces the psoas right at L3-4. I used to tell people do L3-4 first, but then people would tell me, what is this thing that I keep seeing that made me abort? Well, it was the genitofemoral nerve. It's usually about 2 centimeters posterior to the anterior edge of the psoas down to L4-5, but right at L3-4, it can pop out right at the anterior edge of the psoas and sort of freak you out. So that's why I don't say L3-4 is the starter level anymore. Also, there's a weird muscle called the Psoas Minor. This is not a hip flexor. If you saw this on an isolated MRI cut, you'd think it's a vein. But if you follow it, you'll see it blend with the psoas cranial and sometimes completely separate from the psoas caudal. And it goes down and inserts on the iliopectineal line of the pelvis. So you expose, you look, and you visualize it. You find its anterior edge. And if it's super adherent and the genitofemoral nerve is behind it, I'll go behind it. If the genitofemoral nerve is on it, I'll detach it and push it back. But with these, a separate one like this, it's actually not too hard to go behind it. And it seems to be much more firmly adherent to the vertebral body than the psoas major. But if you're looking, you're going to see it. But look on your MRI and notice how it's asymmetric. It's only on the left side of this patient. You'll see this more than you know. Here's a femoral nerve. So following through the multiple sequential cuts, here's a femoral nerve. It doesn't mean you can't do this case. It just means that you got to land more anterior. I usually land at about the 50-yard line with my first dilator that I punch a hole in the disc. I might land more anterior with this one and not work so far posterior with this femoral nerve. And I kind of marvel at the asymmetry of these things. This is totally different than the right side. So you got to look at the anatomy where you're going to land. So discectomy and dilation. Here I am landing at the anterior third to get out a PLIF cage that ended up in the epidural space in this non-union I was sent. So for these kind of cases, I'll make my incision more than 2 finger breadths anterior to the mid-sagittal line, as you may have heard. I'll make it 3 or 4. I'll make my incision much more ventral, dissect a little bit more lateral, but then I can pull the whole wound down and shoot into the disc space flatter to the floor, which I find is easier to get these kind of cages out. I've probably taken out 25 or 30, and probably 5 of them have been my own. Fortunately, they're not so hard to get out. If you're going to use the shavers to get back to it, I would advise you to use a blunt shaver, like a PLIF shaver. Most of the shavers for direct lateral and OLIF are end cutting. The flatter shavers, like for PLIFs, they are not end cutting. And so if you're using it on a flatter trajectory, you're less likely to have it go too far posterior if you use a shaver that is not end cutting. Why do I know? Because I did it once. So where I like the anterior approach, now I've taken all my retractors out and I'm dilating. You probably can't hear it. Oh, you can hear it. You hear that thump? So since you're pre-psoas and on bone, So you can't do that trans-psoas. You know that you are thumping and landing right on the bone. Again, confirmatory. If you had interesting structures up front, such as a AAA or maybe an ascending lumbar vein, you might leave that medium ribbon retractor in the front while you're dilating and replacing your retractor. Again, being a chicken, creating an armor-plated exposure and working channel. Do you pin or not? I always pin, and I usually pin cranial. This pin placement, where this is going to go, is about as caudal as you want to go. I don't find that the segmental is at the midpoint. I find that it, for some reason, seems to be a little bit cranial of the midpoint of the scallop of the vertebral body. I've gotten it 3 times in several hundred cases. A WEC clip applier is a simple thing to fix it, but it's just no fun because you're just getting done with your case, you pull the pin out and it starts bleeding. It's not a problem. You can tamponade it with your lap peanut, and then you can just clip it with a WEC clip. But be aware that you don't want to go any further south than about there or further north than about there. So here we go. Discectomy. Measure 3 times, cut once. Here's one of my dentists with sympathetic chain dysfunction that lasted about 3 months. His left foot's just a little bit warmer and redder. So if the sympathetic chain is in the way while I'm preparing the disc and do my annulotomy and all that, I'll leave the medium ribbon up front. Some of the retractors have a 3rd blade that will pull things anteriorly so that you can just shove the sympathetic chain toward the midline and not mess with it. So again, another thing with discectomy that I've gotten once. So here is the ascending lumbar vein. Think of it as a small azygous vein. It's going to lay right there. So it's longitudinal. It may or may not compress easily. You may not know what it is, but it and the sympathetic chain both get pushed toward the midline. If you're landing right on the disc, you're not going to have a branch tented over the disc. The branches are going to sort of follow the segmentals on the vertebral body. But if you see this, just pay attention to it and push it toward the midline, like the sympathetic chain. If you happen to get it, which I've done once, a WEC clip applier, you'll need the long one. You can't get the short one. This is spine surgery, big time. Have long tools, not the short WEC clip applier. So here's the cob. I love the cob. So here's my hold down pin, not further north than the pedicle. Here's my cob at L4-5, and I always sing this little song to myself, soft side south is safer. The cobs are ground like ski tips. That's why I got a little ski guy there. So they'll bounce off things. If you're aware of the ski tip side of it, it's ground like a chisel. If you put the soft side south, do an L4-5, because L4-5 is at risk for digging into the end plate because you may be fighting the pelvis. Put the soft side south with your cob so you won't dig into L5. Sneak up on the size. No cob's 3 millimeters, at least in the set I use. The first dilator is 4, the second is 6. The trials are 8, 10, 12, 14, 16. Just sneak up on the size. Here's a perfectly placed pin. Here comes the trial. I've got a long nerve hook holding back the psoas, probably in this case, just to keep the genitofemoral nerve and the interpsoas fibers out of the way. But just sneak up on the size, and the reduction is powerful. Placing trials. Orthopedic surgeons, we use a thing called a blocking screw in tibias. What this is a screw we've placed to force our tibial guide rod to go straight. The same thing applies when I'm doing OLIFs. If I find that the cage is going too far anterior or posteriorly, I'll place one of these smooth dilators in the disc space so it'll force the trial anteriorly or posteriorly. If I'm going for indirect reduction, I'm going to put it posterior. If I'm going for lordosis, I'm going to place the trial more anterior. And sometimes I need to shove something in that disc space so the trial and the cage can't go there. I wouldn't use the shaver. They're sharp. Almost all the sets have these blunt dilators that sort of insert and twist. They're brass colored in my set from my vendor. But they're nice to use as what the concept called a blocking screw. It's a blocking trial. Okay, we're going to put the cage in. I've gotten away from using the ones with the integrated shims just because some of the spaces I work in are very tight. I don't have a lot of extra space. So This particular cage that I use has 3 ways to hold on to it. You can screw into the cage. I use PEEK. I still do. I love PEEK because you can drill it out if you ever had to. You can clamp this one, and then God forbid something goes wrong, I've got a 0 Ethibond stitch looped around it and clipped to the inserter. So I've got 3 ways to hold on to this cage if it ever got lost, which knock on wood it never has. But you hear stories about errant cages going out the front, and now you've got something to hold on to it. If you can't get the retractor back on it, you've got a trail of breadcrumbs to help you find it. You've got another way to pull on it. I used to use tiger wire, and then my OR manager came to me, said, why are you throwing away a $150 piece of suture every day? So I went to a $2 0 Ethibond. So withdraw the retractor. Don't be in a hurry. You've just done a beautiful operation in a very, very important space. So I take a fully unfolded Raytech, maybe some Flow Seal, maybe not. I pack the base of the retractor right where it's meeting the spine on the ass end of the cage, and I hold it there for a couple minutes. And then I take it out. I take my pin out, make sure it's not bleeding. This is a well-placed pin, no way it'll bleed. And then I slowly pull the retractor out and I look around. You can document that your genitofemoral nerve is okay. You can make sure your ascending lumbar vein, if present, is okay. Just remove it slowly and look around. We love anatomy. So before you say goodbye to it, look at it. 2 or 3 times, I've actually gotten bleeding from the hold down pin. So that's required. Bone wax on my lap kidney to get it to stop. And then closure, don't put big bites. Don't put suture through something you can't see because you might bind up a cutaneous nerve or the ilioinguinal or iliohypogastric nerve. I think I did that once because I've got a patient with some anterior thigh numbness that's not lateral cutaneous. So direct vision closure, 2, sometimes 3 layers of the muscle, and then skin. So where's this going to go next? Now that I've done a whole bunch of these and it's been such an awesome operation, anterior decompression. So here's a miserable case. A good, very talented friend of mine knows I do a lot of anterior surgery, and he had done 2 discectomies on this nice lady, but unfortunately he couldn't get the piece out. Here's her L5 nerve root draped over it. Here's our OLIF window. So we did it from the front. She also had a collapsed L5S1 with some foraminal stenosis. So we did a lateral approach L5S1, then a lateral through a separate incision, then a lateral approach L4-5, where we went through our OLIF interval and pulled out this whopper piece of disc. And I could look right down the retractor tube, see the hole in the annulus, pulled this out, saw the hole in the posterior longitudinal ligament with bare blue dura behind it. So this case was done all anterior with decompression and percutaneous only fixation. And she went home a couple 100 miles away. I've talked to her on the phone. She doesn't want to come back in. She was better when she woke up. And I've done this now about 10 times for redo decompressions through the front. I'm never going back there from the back again. We'll just do it from the front, much easier. It involves a fusion, but most of these people need it 2nd or 3rd time around. Posterior fixation. Okay, some of you are going to have robots. We don't. I'm lazy and cheap. So we'll pick up a patient with 1, 2, sometimes 3 levels, put them on the same cheap OR table on chest rolls. Here's my OLIF incision. Hyperextend the table. I call this my budget pro-axis. Hyperextend the table to give them lordosis and do open or percutaneous fixation all on the same table. Never redrape the back table, never redrape the C-arm, never even open the room door. So it's easy and cheap, and I like bilateral fixation whenever possible, and we don't have a robot. So this is my easy, cheap way to do it by slightly hyperextending the table. So thanks for listening.